Bismillah ar-Rahman ar-Rahim. Dear Chairman, dear colleagues, dear guests, welcome in Egypt. I hope you love it. I will speak today about my topic, management of pre-eclampsia and adapting guidelines. I think I will give an example for Dr. Professor Abdelhamid, as what he said before. So let's start. The content will start by steps to do a guideline. I will speak in brief, a pre-eclampsia introduction, an adapted guideline for pre-eclampsia. Let's go to the first question. How to do a guideline? The WHO put several steps to reach to it. It started by the identification of the main question that the recommendation will address, then retrieve of evidence, then assessment of this evidence, then formulation of a recommendation, planning for dissemination and implementation, and lastly, updating of this recommendation. This is a level of evidence of parameters. Start from the meta-analysis, then the systematic review, then randomized control study, then cohort, then case control study, lastly, case series and expert opinion. Based on it, the grade for recommendation, which taking grade A up to D. A, which is based on a meta-analysis or individualized high quality of a randomized control trial. B, based on a meta-analysis or individualized cohort and case control study. C, based on a case series, and D, based on expert opinion. Another interpretation for quality of evidence level according to grade. Here the level of evidence starts from high up to very low, as our professor Dr. Abdelhamid said, and the recommendation, which is more simplest, either strong or weak recommendation. Strong mean we recommend, weak mean we suggest. So let's go to pre-eclampsia now. As we know, it's a multi-system disorder that typically affects around 2 to 8% of a pregnant woman. And it's one of the leading causes for maternal and perinatal morbidity and mortality, especially in the low-resource countries. It accounts around 76,000 in women and 500,000 babies die each year from pre-eclampsia. In Egypt, it accounts a very high percentage, reach from 10 to 12%, and it's responsible about 15% of maternal mortality rate. So let's go to the maternal mortality rate by WHO in 2015. It accounts about 52 Q 100,000 live birth. And as we see, the pre-eclampsia takes the second most common disease lead to maternal mortality after obstetric hemorrhage. Here, as we see as a comparison with Egypt from other countries, we see that Egypt is the lead in the maternal mortality rate. Unfortunately, nothing has changed from the first description of a pre-eclampsia by the father of the modern medicine, Hippocrates. Even after more than 2 millennia, still pre-eclampsia remains a multi-system disorder of unknown etiology. So it's a time to update. It's a time to see to our guideline and to try to update our guideline. So this is an adapted from the international guideline to try to cope our locality. We get it from the International Society to Study Hypertension in Pregnancy in 2021, ACOC 2020, FIGO 2019, NICE 2019, and WHO 2018. The guideline will include first what is the definition of a preeclampsia, then what is the maternal risk factor, what is the recommendation for, how we can predict preeclampsia, how we can prevent antenatal, maternal, and fetal surveillance. What about antihypertensive therapy? What about magnesium sulfate therapy? What about time and mode of delivery? And lastly, the postpartum care. About definition, it is a systolic blood pressure is more equal to 140 and or diastolic blood pressure is more equal to 90. It should be on 2 occasions measured 4 hours apart, with 1 or more of these new issues appearing after 20 weeks. Either proteinuria, more than 300 milligrams per day, or more than 2 tibistic, and evidence of other maternal organ dysfunction, like acute kidney injury, liver involvement, neurological complication, hematological complication like thrombocytopenia or DIC, and uteroplacental dysfunction. About preeclampsia with severe feature, which is defined by the ECOG, the systolic blood pressure is more equal to 160 and or diastolic blood pressure more equal to 110. Appearance of visual disturbance, new onset headache which is unresponsive to treatment, thrombocytopenia, impaired liver, renal function about doubling of the function, severe persistent right upper quadrant pain or epigastric pain, and it's not also responded to any treatment, and pulmonary edema. Subclassification of a preeclampsia, which is not approved yet. One is the early onset of a preeclampsia, delivery is less than 34 weeks. A preterm preeclampsia, delivery less than 37 weeks. A late onset of a preeclampsia, delivery is more than 34 weeks, and the term delivery at 37 weeks. So let's go to the maternal risk factor. We much to be alert about it as we can prevent this disorder. It's divided to high and moderate risk factor. High, if the patient had history of a preeclampsia, pregnant on top of ART, obese patient, with chronic hypertension, with type 1 or 2 diabetes, renal diseases, and autoimmune disease. And moderate if the patient is nullipara, with multifetal gestation, with family history of preeclampsia, her age is more equal to 40 years old, or with previous adverse pregnancy outcome. Let's go to what is the recommendation for preeclampsia prediction. In first trimester screening between 11 and 14, we can record the maternal risk factor, and measuring the mean arterial blood pressure, measuring also of the uterine archipulsatility index. Combination in between all these measures also can be considered. And measuring of the placental growth factor as a step with these procedures, which is named as a triple test also. What about recommendation for preeclampsia prevention, how we can prevent? So all the international guidelines agree that any women with identified to be a risk for preeclampsia should receive aspirin before 16 weeks at a dose around 75 to 150 till delivery. Calcium supplementation is recommended, but it's a weak recommendation, especially in a low dietary countries. But for all women, and I mean here all healthy women, she should exercise in a pregnancy to reduce the likelihood of gestational hypertension and preeclampsia. Well, what about the others? So we don't recommend for folic acid anymore, vitamin E, vitamin C, heparin to prevent preeclampsia. It does not work. What about recommendation for the surveillance? What we should do with the patient with a preeclampsia? So let's start. Any women with preeclampsia should be assessed first at the hospital. She should increasing the clinical antenatal visit for her up to twice weekly with education about the severity of the symptom. Maternal lab test in a form of CBC, liver, kidney function test should be done 1 or 2 times per week. Perform ultrasound every 2 weeks to assess the fetal growth, liquor volume, umbilical artery Doppler. If ultrasound is not present, we can use the cerebral symphysis fundal height. Recommended CTG at diagnosis, and if clinically indicated only. Let's go to the antihypertensive. When we will start antihypertensive treatment, it should be started to remain above. If the patient blood pressure reaches to 140/90, we should start antihypertensive treatment. And our goal here to reach to 135/85. We offer labetalol, nifedipine, and methyl-dopa as the first line of treatment. But in cases of severe preeclampsia, we offer labetalol, oral and IV, and oral nifedipine, and IV hydralazine. It should be urgent and in a monitor setting. What about the recommendation for magnesium sulfate therapy? It is a gold standard, so it's used to prevent eclampsia and recurrent seizure as a neuroprotective agent. The standard dose will be the loading, 4 grams intravenous, followed by the maintenance, which is 1 gram per hour intravenous for 24 hours. We don't recommend for plasma volume expansion, and please, we don't recommend for corticosteroid to treat HELP anymore. So we can summarize intrapartum management as we have 2 main goals. One is the prevention of seizure and 2 control of hypertension. with appropriate management of labor and delivery. So let's go to the time of delivery when I should deliver this patient. If the patient with pre-eclampsia, we can offer expectant management if the patient less than 34 weeks, and in between 34 and 36 plus 6 if there is no other indication. But we recommend induction of labor if she reaches to 37 weeks. For cases of severe pre-eclampsia, we recommend delivery if the fetus is not viable, and if the baby reaches to 34 weeks. Expectant management for severe pre-eclampsia less than 34 weeks is based on a strict selection criteria, so it takes weak recommendation, and for our locality, I will say no. There is a recommendation for immediate delivery, irrespective of the gestational age. Yes, there is urgent. At what condition? If the patient had stroke, eclampsia, pulmonary edema, oxygen saturation less than 90%, repeated visual scotomata, severe intractable headache, severe uncontrolled hypertension, a progressive thrombocytopenia, a progressive deterioration in renal and liver function, abruption with maternal and fetal compromise, non-reassuring fetal state, and IOFD, and I get a red line under IOFD. Please terminate. What about recommendation for mode of delivery? Should be vaginal? Should be cesarean? Let's see. So it depends, determined by the routine obstetric considerations. The cesarean delivery here is individualized according to the clinical assessment and the woman preference. But we can summarize the indication of cesarean section in cases of a preeclampsia in this situation. Urgent determination we need with cervix is unfavorable. Severe preeclampsia with suspect prolonged induction of labor. Other complicating factor like elderly primary, contracted pelvis, malpresentation, abnormal CTG, and so on. What about recommendation for postpartum care? Now the patient is delivered. What should I do? First, continue antihypertensive treatment and blood pressure monitoring. 2, measure at least 1 in between 3 to 5 days after birth blood pressure, as there is shooting at this time of the blood pressure. You can discharge the patient from hospital when she has 1, no symptom of preeclampsia anymore. 2, blood pressure is less than 150/100. Blood test results are improving and stable. Of course, we recommend for breastfeeding and counseling about the suitable type of contraception, and long-term health risk also is recommended. So our conclusion here, implementation of a guideline is a constant challenge. Preeclampsia is responsible for a high percentage of a maternal fetal morbidity and mortality. More research to study preeclampsia is required. Women with preeclampsia should be asked to participate in researches and clinical trials. Egypt should promote more researches aiming to improving its research base to help in creating its own guideline. Thank you.